Hello everybody and welcome to Facebook Friday. I am Kate Wakeland from Neuroendocrine Cancer Australia. I'm the NET patient support nurse, and every Friday we do a live broadcast into our private discussion group to really drill down and look at a topic in a little bit more depth. So I'm hoping this week I'll be able to see people joining and putting in comments, because last week nothing wanted to play with me, but fingers crossed, new week, sun's shining in Melbourne, so you never know. This week we're going to talk about peripheral neuropathy, but as always, there's a couple of things that I'll do first. The first thing is just to acknowledge the traditional owners of the land that I am broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation. And I would just like to take this opportunity to pay my respects to elders past, present and emerging. One of the things I love about where I live is living very close to the Yarra River, which I know is a really spiritually significant body of water for the Wurundjeri people. I love to go running along the river, and I feel very grateful for where I am. In the Woiwurrung language, it's called the Birrung. And I know that people are joining me from all over the place, so just extending that acknowledgement to where you're joining me from. So I can see that a few people are watching. Can't see any comments, so say hi if you can see me. We'll see if we can see the comments. If it continues to play up for us, we might need to find a different way of getting questions to me, because I really want to be able to respond to questions live as we go. So anyway, we'll just monitor the situation and see how it travels. Not getting anything yet. Anyway, so the other thing I wanted to just let you know is we keep monitoring the situation with coronavirus in Australia. Oh, I can see a comment. Hooray, thank you. Brilliant. Coronavirus, I have managed to score myself a vaccine over the weekend. So I'm like lots of people in phase 1B, so that's health professionals, but also people with active cancer in phase 1B. And if you're over 50 in phase 1B, then actually vaccinations will be available now, or very soon available, and I'll make sure there's a link in the notes to where you can check your eligibility for the COVID vaccine. For people under 50 in the 1B phase, there was a little bit of a lack of clarity about what the recommendation was, how people in that category were going to get their vaccine, because AstraZeneca was no longer recommended due to the very unlikely but serious risk of blood clots. If you're in Melbourne, I can actually help you link in. If you're having trouble finding where to get a Pfizer vaccine, there's a few places that are doing it. Actually, also at least one of the regional hospitals. I think the best thing is to call your GP and ask them, and they'll probably have more information about what's available in your local area. GP surgeries aren't giving the Pfizer vaccine because it needs to be refrigerated at some ridiculous, or in a very, very, very cold freezer. So most clinics don't have capacity to refrigerate them for so long. Look, this is my personal opinion, but I just feel like the information flowing out about where to get the Pfizer vaccines for people in 1B under 50 has been a bit lacking. I hope that's okay for me to spout my personal opinion there, but I just managed to ring and get through to the Austin Hospital. So if you're in the northeast of Melbourne, the Austin, I got in within 2 hours of making the phone call. They were lovely. I got a lollipop and a sticker. Got a bit of a sore arm, felt a little bit wonky the next day, but I still went on a 10-kilometre run. So probably if I hadn't known that I'd had the vaccine, I probably wouldn't have paid any attention to just feeling a little bit kind of headachy. But for people, if you're having that vaccine reaction, that does mean that your immune system's having a response. So I think that's actually good news, that I felt a little bit weird the next day. I had a sore arm the sore arm was a little bit more sore than the flu, but not bad enough that I couldn't use it as an excuse not to pick out the washing. So anyway, I just thought I'd let you know about my experience of that vaccine. And maybe if you're a person with NETs in our private discussion group and you've had your vaccine or you're having it, and you want to share what that experience has been like for you, I'm sure that's going to be really interesting to other people as they follow along. So I just encourage you to put your comments in there when, or post a selfie if you want to in the group as that happens. So down to tin tacks on our topic, and I thought I almost called it a back to basics video, and I thought it's not really that basics, not that basic. So once I started to do a little bit of homework and reading on this topic, I thought, oh my goodness, I really did pick a doozy. I thought I'd be able to cover this really quite quickly, and I will try, I promise you, but it is quite detailed. So we're going to be talking about peripheral neuropathy. It's a mouthful and it's hard to spell, a little bit like neuroendocrine cancer or neuroendocrine tumours. Peripheral neuropathy is pain or weird sensations that are caused by damage to nerves. And look, I'm not going to just be giving an overview today, so I'll put some links in the notes for people who want to dive a bit deeper into it. But there's different types of nerves that can be affected. So we're going to talk about the peripheral neuropathy that most people think of, which is causing the sensations, the weird sensations in particularly in your fingers and toes. So yeah, but it's because of damage or impact on the nerves, and it's different to, it's not always pain. So that's something that people often think. It's a bit of a myth that it's always painful. It's not always painful. There's actually lots of different things that it can feel like. Certainly you can get pain, so particularly kind of tingling or pins and needles or stabbing or shooting pain. Sometimes burning pain can be a symptom of peripheral neuropathy, but also some other weirder kind of sensations. So sometimes it's more of a shimmering feeling rather than something painful. Or just weird sensations. Now, I've got a really good friend, very close friend, who developed peripheral neuropathy, having had oxaliplatin, which is a chemotherapy that people with NETs are sometimes given. She said it was like walking on wet plastic bags inside her shoes. So she felt like her shoes were slippery, like her feet were slipping inside her shoes. And the other thing that she said was that she felt like she couldn't really feel where her feet were. So things like walking down the stairs became much more scary because she was worried about falling. And actually we know that people with peripheral neuropathy in their lower limbs are more likely to have falls. So you can also get sort of numbness and weakness, muscle weakness, and also muscle cramping is another thing. So I know that these are symptoms that people with NETs often experience. Doesn't necessarily mean it's peripheral neuropathy. So muscle cramps and weakness can be from other things as well. So I think that my biggest overarching take home with this is the same as always when I do a Facebook Friday is, please talk to your doctor about your situation. So this is just general information, but for your own situation. And if you're experiencing peripheral neuropathy, what I'm saying today might not be appropriate or applicable to you. So always talk with your doctor about your own situation. So I'm just going to check in my notes. I've got a few notes, so you'll see me looking down. Just wanted to see if there was any others that... the other thing that my friend said, she's a nurse, and she said that her fine motor skills were reduced. So she's a person who puts teeny tiny intravenous needles, drip needles, into teeny tiny premature babies, and she found that it was her accuracy in putting in those cannulas was reduced. So her fine motor skills in her fingers and her hands were impacted by that peripheral neuropathy. So what causes it? And look, there's like lots of things, there's lots of different causes, and it's not always cancer. And I guess the thing about having cancer, especially as we get older, it's not a get out of jail ticket for any other thing that can kind of go wrong with your health. So it's really important, if you have symptoms of peripheral neuropathy, it may not have anything to do with your NET. And that's important to know so that you can make sure you get assessed. So please don't put up with these sorts of symptoms and not bother talking to your doctor about it or your nurse about it, thinking, well, of course I've got peripheral neuropathy, I've got NETs. That's that's not what we want you to take away from this video. So there's lots of actually different causes. So diabetes is a really common cause of peripheral neuropathy. There's also a whole swag of autoimmune diseases that can cause peripheral neuropathy. I'm not going to go into all of these things and the way they bring this about, but important that you know that it's not just NETs and it's not just cancer. Sometimes we never find out why the person has peripheral neuropathy. So and actually my mum is one of those people. So she has ongoing issues with pain in her legs, peripheral neuropathy pain. They've never really worked out why, and so that's difficult. And I guess the thing about these sorts of issues that can cause pain and significant alteration to the quality of your life, is that there is a physical impact. There is the physical management, but there was also this broader kind of issue of suffering, that it's not just a physical experience. It's actually whenever anything is impacting our experience and our sensations, it's an emotional experience as well. And it's also important, along with the physical management and taking drugs and that sort of thing, it's really important to be looking after the whole person, and that includes taking care of our emotional selves. And if you're a person who's experiencing peripheral neuropathy, we need to be looking at your emotional well-being and making sure that you're getting appropriate support given that experience for you. Viruses can also cause peripheral neuropathy. So shingles is a key one that often people have experienced, and actually sometimes that can be linked to cancer, because if you're going through chemotherapy or you're just going through a really, really stressful time and you're a bit run down, which can happen with cancer, people can be more prone to having a flare-up of shingles, and that can definitely cause peripheral neuropathy as well. And so, yeah, I'm going to start talking about the cancer-related causes of shingles, because I can see some people talking about these in the comments. So it's a really good segue. So there are some tumor-related. Did I just say shingles? Look, who knows? It's Friday and I'm still waiting for my second cup of coffee. The magic coffee fairies haven't arrived yet. That's afterwards. So there are some cancer-related causes of peripheral neuropathy. One of the first ones that I'm going to talk about is direct cancer cancer directly impacting on a nerve. And so what we can find is that you can get a tumour that's actually growing very close to a nerve, and that can actually cause pressure directly on the nerve, or sometimes it's just that there's a lot of swelling around the tumour. So actually we get that in people's brains. If they've got a brain tumour or a metastasis in their brain, we often get a lot of swelling as the body kind of deals or tries to deal with this foreign thing growing, and that can cause pressure on the nerve. So if that's, for example, in a nerve pathway, in a limb, or on the spinal cord, we can get peripheral neuropathy symptoms. And I'm going to talk a little bit more about the sorts of things to watch out for with spinal cord issues, because that can be very serious. So we want to make sure that we don't just put up with things if they're changing. So tumor impaction, swelling related to tumours, and actually sometimes you can have a tumour, and I've had this has happened a couple of times where people have had a tumour in their abdomen or in their pelvic area, and if that tumour is bulky or there's associated swelling with that tumour or with the operation, that can cause peripheral neuropathy. And sometimes that's not even related to a tumour. Sometimes it's just that you've had pelvic surgery. So I've had people who have had patients who don't have cancer but have needed to have an operation on their pelvis for example, a hysterectomy, and for the first few weeks after that operation, because of all of the swelling in the pelvis, those little channels where the nerves pass through into the legs are really, really tiny. You can just get peripheral neuropathy, so numbness and tingling and weird sensations in the legs just from having an operation. So swelling was so direct. I'm trying to go through. I don't know if you can see my notes. They are a dog's breakfast. I just want to make sure I've mentioned everything to you. The other thing that a lot of people with cancer have, and that we think of a lot when we talk about peripheral neuropathy is chemotherapy. So that's called chemotherapy-induced peripheral neuropathy, or you might see it shortened as CIPN for short. So there are particular drugs that are known to cause peripheral neuropathy, but there's actually lots of different drugs. And, you know, someone's mentioned capecitabine in the notes, which a lot of people have as part of the CAPTEM regime for NETs. But the other one, which is a common culprit, and it does get used in NETs, particularly those that are growing a little bit more quickly, is oxaliplatin or carboplatin. So they're and actually cisplatin. So that platin group of drugs are known to be pretty nasty to the nerves, and that can cause problems. Sometimes people experience that symptom the first time they get the drug. Sometimes that's after you know, they might have had 8 or 10 cycles of the drug and they start experiencing those side effects. So everybody's a bit different with how sensitive their nerves are to the damage from those chemotherapy drugs. And I'm going to talk a bit about managing peripheral neuropathy in a minute. But before I do, I wanted to talk to you about a really important thing that can happen in NETs that's sort of fairly unique to NETs in cancer. So you won't see it. For example, there's a fantastic peripheral neuropathy brochure from the, or fact sheet that's got 9 pages from the Cancer Council. I'll put the link to this one in the notes and you can download it, but you won't really see very much about this issue in the general one because it doesn't happen very often in other sorts of cancers, but it happens quite a bit in NETs, and that is vitamin B3 deficiency. So I'm going to talk about this very briefly and link to other things in the notes about vitamin B3 deficiency because it is a bit complicated. But essentially, for people whose tumours produce too much serotonin, in order to make all of that extra serotonin, the body uses the stores of a peptide called tryptophan. And tryptophan is also involved in the body's synthesis of vitamin B3. So that's a complicated pathway that I've just explained in one sentence. But essentially, if your body's producing too much serotonin, you're very likely to be deficient in vitamin B3. And you'll know that your body's producing lots of serotonin because you'll be a person who gets carcinoid syndrome. So that's the flushing of the face, diarrhea, wheezing or shortness of breath. Sometimes I was going to use a medical jargon, but the racing heartbeat, we call that tachycardia. Sometimes hyper-anxiety episodes can be a symptom of carcinoid syndrome. So if you're not sure if you get carcinoid syndrome, then you can talk to your doctor or you can contact me and I can help you sort of troubleshoot what your symptoms are. There's other things that can cause diarrhea. There's other things that can cause hot flushes. So it's not always the case. And also sometimes people have quite a lot of serotonin in their blood or their urine tests and they don't get the symptoms. So it's all really complicated. There's no straight answers with NETs. It's always a little bit complicated. But if your tumours are producing lots of serotonin, you are likely to be deficient in vitamin B3. And a vitamin B3 deficiency over time can lead to peripheral neuropathy. So it's really important that if you are experiencing carcinoid syndrome, or if you have serotonin producing tumours, that we actually talk about a vitamin B3 supplement. And I'll make sure there's links to that in the notes. I'm going to not labour that today because I'll be still here in an hour and you'll all be dying of dehydration and busting for the loo, and so will I. So I'll put a link to that in the notes. I'm just going to have a look because someone's put a little thing. Yeah, so someone's talked about a syndrome called, and I don't know how to pronounce this because I've only seen it written on a page, Wegener's maybe, or Wegener's syndrome. So that's an autoimmune condition that can cause peripheral neuropathy. And I'm really glad you mentioned that in the comments because, yeah, there's lots of actual autoimmune the autoimmune problems that can cause this issue. So I think the thing that we want to know is that can it be helped? If you've got peripheral neuropathy, can it ever get better and not need ongoing management? And if it needs ongoing management or even management at the time, what do we do about it? So I'm going to talk about that now. The first thing is that it's not always permanent. And I mentioned an example before where someone might have had an operation on their tummy or their pelvis, and we've got swelling in the pelvic area. You can have peripheral neuropathy for just a couple of days while there's that swelling. For someone who's had if there's an issue with tumor mass, you might have some surgery or some radiotherapy or some chemotherapy to reduce that mass down. And once that swelling reduces or the tumor mass is reduced, we might get an improvement in the peripheral neuropathy. The other thing that we can do is if there's lots of swelling around a tumor and that's contributing to pain or peripheral neuropathy, steroids can be used really with very great effectiveness. So you might have heard the drug dexamethasone causes got lots of other nasty side effects, but it can be used when there is swelling due to a tumour, and that can actually help with the symptoms of peripheral neuropathy. And the really important thing for you to know about that is that if you're experiencing peripheral neuropathy that's painful and they're using drugs to treat that peripheral neuropathy as well as some other things like radiotherapy or steroids, you might experience an improvement or a resolving of that symptom, and the drugs that you needed 3 or 4 days ago, that might reduce. So it's important that you are doing this in conjunction with your healthcare professional, with your doctor, so that they can monitor you for, what might have been an appropriate dose of medicine 3 or 4 days ago might be more than you need now, and it might leave you feeling bombed out and getting more side effects than you need. So this needs to be monitored quite carefully. So if the cause of the peripheral neuropathy resolves, then we can get a resolving of the symptoms. So that's really important that you know that. It's not always permanent. And the other thing I think we should acknowledge is that even if we think that sometimes it can be permanent, and so I'm going to talk about the chemotherapy-induced peripheral neuropathy now. Sometimes that can be long-term. I think they don't have great data on the very, very long-term impacts of this. And actually, at the end, I'm going to point to a couple of clinical trials which not only are looking at the management of peripheral neuropathy, but also measuring the impact for people, and I'll put some links to those in the notes. But so my friend who had her oxaliplatin, she had bowel cancer, and that was 10 years ago. And when she was coming out of her chemotherapy after that bowel cancer, she had quite severe peripheral neuropathy. She was one of these people who was worried that if she mentioned it to her healthcare team, they might reduce the dose, and she was really, really super keen. Don't be like her, because she actually couldn't work for a while because the peripheral neuropathy was so bad. So always talk with your healthcare team if you're experiencing these symptoms. But what actually my friend found was that over time, these symptoms actually improved. And it was over a far longer period of time than her healthcare team had imagined. So 10 years later, after that chemotherapy, she was still finding that it was getting better. And now she's able to go bushwalking quite confidently. She's very much back at work, putting those teeny tiny needles into those teeny tiny veins, and that's having much less of an impact on her life. I don't think it's gone away completely. And you could argue that she's got used to it, which maybe she has, but look, that's okay too, isn't it? That she's become more tolerant to those sensations. So it's not always permanent. But I guess if we are finding that you've got peripheral neuropathy that needs managing, either in the short term or in the long term, there are a number of ways that we use to manage that. And the really important thing is that if you go to your doctor saying, I've got numbness, tingling, pain, muscle cramps, shooting pain, those sorts of issues, if the doctor prescribes you one medicine and you try it and you think that's not doing any good, or I'm getting worse side effects from the medication than I was with the peripheral neuropathy in the first place, please don't give up. There's more than one road to Rome, and there's lots of different things in the toolkit for peripheral neuropathy that we can try. But I think a lot of the time people try one thing and they think, oh, well, that's it. I've tried the treatment. It doesn't work. I've then got to put up with this. And no, you don't have to put up with this. sometimes it takes lots of goes of different things to find something that works for you, and sometimes it's a combination of things. So don't give up on it. So the first thing we need to do is work out what's causing it. Is it that there might be an undiagnosed diabetes that we've got to work and get right on top of? There might be an autoimmune condition that is developing that we need to get on top of. Maybe there's chemotherapy that you're having, and if this is a serious side effect, and there might be an alternative chemotherapy that they can consider. That's a conversation for you to have with your healthcare team. They're not going to say, no, you can't have the treatment, but it's really important that you look at all of the options and work out what might be possible. We want to, if you're having sensation difficulties, especially in, for example, your feet, we want to protect we want to protect you from injury, especially if you're numb. We want to make sure that you don't injure yourself and not notice that you've got an injury because you're not feeling things in the same way. So you need to make sure that you've got really well-fitting shoes that aren't rubbing. You need to monitor the skin on your feet for signs of wear and tear and redness and blisters and tiny cuts. You need to take special care of your toenails, because you won't necessarily feel the same sense of this toenail needs trimming or this toenail's digging in, or I've got an ingrown one. You need to actually pay special attention for any signs of redness or infection or injury to your feet. The other thing is that there using clothing or sheets that are softer and less abrasive can help with that. If you've got that real jangling pins and needles pain or sensation, touch can be really problematic. And if you've got sheets that are very crisp linen and coarse, then that might just make it more difficult to sleep, or it might make you more likely to wake up if you're having a snooze. Having softer sheets like bamboo or silk or satin might actually make that less inflamed for you and might make it easier to sleep. Having soft, well-fitting socks, make sure the seams on your socks aren't digging in. Some socks, they just have those seams right over the top of your foot, and when you put on a shoe, that can be digging into your foot, and you might not feel it, so it might cause an injury, but you might actually find that exacerbates things when you're walking. So making sure you've got well-fitting shoes and socks, you're using soft products. Sometimes using some hand lotion or some foot lotion or some Sorbeline on the skin can just help smooth that and make it easier for less sort of prone to that kind of abrasion. So that's they're all things that we can use to help manage them. If you're having cramps and muscle stiffness, or you're less mobile because of the neuropathic pain, exercise is a really important intervention. Sometimes it's about stretching the muscles and actually increasing the mobility of the nerves within the nerve sheath. That can be, and these exercises can be prescribed to you by a physiotherapist or perhaps an exercise physiologist, and they're really important people to be consulting if you're limited because of your peripheral neuropathy, or if you're actually limited because of your cancer and your cancer treatment. And they will help you find ways of exercising, ways in that are fun, that are doable, that won't, will manage things like fatigue and other symptoms and side effects. Monitor for safety if you've got unstable carcinoid syndrome, all of that stuff. So I couldn't recommend highly enough seeing a physiotherapist or an exercise physiologist, particularly if you've got peripheral neuropathy. There's a number of other non-pharmaceutical or non-drug things that we can do to help with peripheral neuropathy. So I'm going to work through those, and then I'm going to talk about medication and other treatments in a minute. So one of the ones that we don't hear about very much at all, but this is a really useful intervention for both pain, any sort of pain, but also peripheral neuropathy, and that is use of a TENS machine. Let me try and remember, I just wrote TENS down, but it's transcutaneous endothelial nerve stimulation. I've got that wrong. Someone might want to correct me in the notes, or I'll put it in the notes. You can actually buy cheap TENS machines from a pharmacy or health supplies shop. I found a really cheap TENS machine online that I use sometimes if I've got a bit of a flare up in running injuries. I actually find that really effective. So obviously check with your own doctor or your physiotherapist or your exercise physiologist. But TENS machines, they don't work for every person, but for me, they work for some sorts of pain. And there is some literature out there to suggest there is evidence for using TENS machines in neuropathic pain, or peripheral neuropathy. So it's worth a try. Someone's just said Aldi. And I know they did have them at Aldi a couple of weeks ago, so it'll probably be like another year before Aldi have them back in again. Yeah, you can get them cheaply, and look, it's a non-addictive, non-pharmaceutical way of, sometimes that could be worth a try. So obviously you have a talk to your healthcare practitioner. There are some contraindications. There are some things you shouldn't use it. Some people shouldn't use a TENS machine, for example, if you have a pacemaker. So do talk with your doctor about it before you leap in with that. But it is a relatively cheap way of giving it a go, of seeing if there's something that will help. Two other non-pharmaceutical things that I'm going to talk about. The first thing is massage. So it sort of sounds a bit counterintuitive to be massaging an area that is that's painful, but a qualified massage therapist can actually work very, very gently. Sometimes they might work over the top of your clothing, so you're not getting that direct friction on the skin. But there is some evidence that massage can be helpful for peripheral neuropathy. And the other one that can be useful is acupuncture. Once again, we don't hear very much about acupuncture. I think because it's not branded by a pharmaceutical company, so we don't get ads for them. The doctors don't get ads for them, and sometimes I feel like they can kind of forget that that's a thing that can be used. But we've got one patient on our Facebook private discussion group. I don't think he's watching right now, but he had oxaliplatin, so the same drug that my friend had that caused her really nasty peripheral neuropathy, and he was experiencing very similarly some nasty peripheral neuropathy, and he has found that the acupuncture has been so helpful that he's been able to go back on the therapy, and that's actually making his tumours shrink. So I'm so thrilled that he was able to think outside the square, and his team were able to think outside the square. He's been able to access that, and it's why would you treat pins and needles by putting pins and needles in? Like, again, it's a counterintuitive thing. It doesn't involve a drug, so, was it really going to work? But there is strong evidence out there that acupuncture is worth a go. So we do have, look, it's from years ago, and maybe if people are interested, I might actually see if she would come into our Facebook private discussion group. There is an acupuncture therapist, traditional Chinese medicine therapist called Christine, who came to our Melbourne support group some years ago now, and did a talk on acupuncture in cancer, and specifically around NETs. The thing I liked about Christine was that she sits in a very complimentary way to the healthcare team, and is quite open to the idea of working with the doctors and the health professionals who are treating your cancer, and making sure she's not suggesting something that's going to be against what the treatment will be. So she's used to working with pharmacists, as she's also a naturopath, so working in with the treatment team, which is so important when you're talking with a complementary practitioner. So we've got a recording of Christine's talk on our YouTube channel, but look, it was filmed on a really, really old phone with no microphone. I know it's really quiet, and I think probably the images are really not great either. I might actually contact her and see if she would be interested in coming in and having a conversation on Facebook Friday. Let me know if you're interested in that, because I think, sometimes it can be really nice to hear from people who are not me about these things that are their area of expertise. So let me know what you think about that. The other thing that we need to do, if peripheral neuropathy, if you're if it's related to a vitamin deficiency, we need to correct the vitamin deficiency. So that might be going on a vitamin B3 supplement. But the other thing that anecdotally this sometimes helps with cramps is taking a magnesium supplement. So look, if you're going to go onto a vitamin B3 supplement or a magnesium supplement, talk to your team. Sorry, I'm broken record with this, but you know me, I'm always going to advise you to do that. So I'll put some links about vitamin deficiencies and how to correct them in the notes. So the other thing, the other non-drug thing that I wanted to talk to you about, which is, there's very little about this in the literature, but I did want to mention it, and that is, let me see if I can say this term without stumbling over my words. It's interventional anesthesia. So there's just a couple of papers that I did find in my travels that talk about the use of nerve or epidural or intrathecal infusions, so to numb the nerves that are damaged, that's causing the problem, and sometimes actually the use of nerve blocks. Now I've seen nerve blocks being used really successfully for other pains that have been very, very difficult to manage with just medication and other things alone. It's a very, very specialised area. I think there's probably at least one person watching today who has had a procedure done with an interventional an interventional anaesthetist. What they do is they'll often do these nerve blocks or these procedures under like a CT guidance or ultrasound guidance, so they make sure they get the anaesthetic agent or the blocking agent in exactly the right spot. Sometimes they'll use like a temporary block to try it out and see if it works. Sometimes they'll put in like a temporary catheter and give an infusion of a local anaesthetic to see if it works. So these are down the list of things. Certainly we try all of the other non-pharmaceutical things like massage and acupuncture and protecting and all that sort of thing. But it's worth you knowing about this, because sometimes our healthcare team might not think about it. They might need to refer you to a different hospital for it, so they might not be sort of top of their mind. But if you are suffering because of peripheral neuropathy and you feel like you've tried all of the other things, it's really important that you know about this so you can talk to your healthcare team about it. Someone's just mentioned in the notes that they used a myotherapist, so a medial massage person, and they did dry needling. Now, dry needling is an interesting phenomenon. Again, it's like, so dry needling is when they put a needle into the muscle body. It's a bit like acupuncture, and actually often they'll use acupuncture needles, but it goes right into the muscle body. They're not really sure why it works. I had it done for a frozen shoulder, and it made me feel a bit wonky because I don't really like needles, which is not great for a nurse, can I just say? But it was actually really effective for my frozen shoulder. So that's interesting that this person has found that dry needling was useful. So I've talked about lots of non-pharmaceutical things. I want to talk a little bit about drugs, knowing that I don't prescribe drugs and I'm not going to give you advice about what drugs to try or what drugs to use. But sometimes people ring me and they say, I've got pain and my doctor put me on an antidepressant. Does that mean that they're not believing me that I've got pain and they just think I'm low or needing cheering up? And it's not that at all. So with we call it neuropathic pain or peripheral neuropathy, those sorts of nerve-related pains, there's actually a whole raft of different drugs that we can use, not just traditional pain-relieving drugs. So it's really important that you know that. And some of the drugs they'll use are drugs that work on brains, which is a big nerve essentially. So sometimes it's antidepressants that can be used, sometimes it's anti-anxiety drugs, sometimes it's local anesthetic drugs. So don't be too surprised if your doctor's prescribing you a drug that's not morphine or endone or tramadol or, the drugs that we often think of to be used for pain. Often they don't work so well for neuropathic pain. So the problem with that is that to get a level of morphine or opioid drug that will control the neuropathic pain, you might be really, really bombed out and having other nasty side effects. So sometimes they'll combine morphine or those opioid drugs with a another drug. So there's an anti-epileptic drug called gabapentin which can be used. There's another one called Lyrica. Sometimes it's an antidepressant drug, and they'll often use various combinations of drugs. So obviously this is quite a complex area, and if you are seeing a GP or an oncologist to try and get to the bottom of this and you're just not getting anywhere, sometimes you do need to talk to a specialist in pain control, and often that's a palliative care physician. So this is the other thing that sometimes people panic about, having a peripheral neuropathy or a neuropathic pain and being sent to a palliative care doctor and sort of thinking, oh my goodness, is there something my oncologist is not telling me about my prognosis? I thought actually my tumour was fairly stable, and here I am being sort of sent off to palliative care. So it's really important that you know that palliative care is not just around end of life care, although it certainly is for that as well. But palliative care, their superpower is symptom management, and pain is like the bread and butter. Pain management is like the bread and butter of palliative care, and they get a bit excited when they see someone who's been put in the too hard basket by everybody else, because it's like, oh, they like a challenge. And I've seen some fantastic results where people have had chronic pain and neuropathic pain. The oncologist or the GP has sort of tried sort of pretty much everything in the book, and they've gone to a palliative care physician as a bit of a last ditch kind of a last ditch effort, just to sort of, well, look, nothing else has worked, let's send you over to palliative care, and they've found the thing that's actually helped. So that's important for you to know about palliative care. So look, I think I'm probably not going to talk too much about medications, because I could go on for another hour about this, and you've already been very patient with me yabbering on. But the thing I wanted two things that are really, really important before I finish talking about peripheral neuropathy is that the first thing is around spinal cord compression, and I mentioned this earlier. And I think probably the reason I feel very it's really, really, really important. I think sometimes when I think something's really important, it's because I've had a personal, like a clinical experience with someone where this might have been missed. And this is a situation where this was missed, where the patient, they presumed that the sensations this patient was experiencing was related to his treatment, that it wasn't anything to worry about, that it was just a, well, you know, you probably should put up with it and mention it to your doctor at their next appointment kind of situation. And it turns out that this patient had tumours, NETs, growing in his spine, in the bones in his spine. And unfortunately, we found out a bit too late that these tumours were actually growing and causing the bones in the spine to impact directly and squash the spinal cord. For this patient, the consequences were dire. So this patient actually ended up in a wheelchair for the rest of his life. And he was a young guy, had young children, and so the consequences of missing this this diagnosis were just life-changing for this person. And I don't want to talk too much about finger pointing or who missed it. He was a rural patient, and I wasn't in the interactions with his healthcare providers, but what I do know is just the terrible feeling in the pit of my stomach when I realised that he'd mentioned his symptoms to a couple of people and they hadn't really cottoned on that this was something so serious. So it's important that you as patients know about these things, so that if you're feeling a bit fobbed off or you're feeling like they're not really getting it, be confident to speak up. Go to a different doctor. Just don't give up on things. If you feel that things aren't right, trust your gut. Keep going back to them, because look, we're all, as health professionals, we're all fallible, and I'm sure that I've missed things that I should have known. We're all human, and it's so important that you get the best care that you can. And sometimes that means, you know, stepping out of your comfort zone and speaking up politely for your own needs. So the symptoms that you need to watch out for in terms of spinal cord compression, I don't want to panic you, because this is very uncommon, this is very rare, but really important. So pain is the first one. Usually people will have back pain, but sometimes it's just symptoms, other symptoms apart from back pain. But if you have severe back pain, it's not being relieved by what's going on, back to the doctor. do not pass go. Do not collect $200. You need to get to your doctor. And look, if your GP is just sort of not really coming against blacks, your oncologist, if you can't get in to see the oncologist and it's severe pain, go to the emergency department and do not leave until you've been assessed properly. So I can't stress it strongly enough, and that's because I've known this patient who spent the rest of his life in a wheelchair. So pain, I mean, don't panic about it, of course. Most people with back pain don't have spinal cord compression, but if we miss that, it's really serious. The other symptoms that we want to watch out for are numbness and tingling, and we call it particularly in the saddle region, which is a very polite way of saying your bum and your genital area. So if you are experiencing any kind of weird numbness or tingling or different sensations or kind of jangly pain in your saddle region, so the area that you would be sitting on if you were sitting on a horse, we want to know about it. Now, not tomorrow, today. Like, this is urgent. We, in radio, I used to work in radiotherapy, and in radiotherapy there was really only one reason that would get a radiation oncologist out of bed to treat someone in the middle of the night with radiotherapy, was for spinal cord compression, because we know that early treatment these things can be reversible. But if we miss it, like it did with this young fellow, it can be permanent. So I've talked about pain. I've talked about weird symptoms in the saddle region. The other one is a sudden onset of urinary incontinence or bowel incontinence. So if you lose control of your bowel and your bladder, or your bladder, that's not common for you. So a lot of women who've had any children at all, and lots of us who haven't, a bit of a cough or a sneeze, will want to be having some poison. And look, we can talk about pelvic floor rehabilitation another time. But if you're sort of been fine, and all of a sudden you're just having trouble with, a little bit of wetting in your pants, or losing control of farts or poo, where you've been okay up until now, we want to know about it today, not tomorrow, not next week, not at your next oncology appointment. You go straight to your doctor about that. So what have I talked about? I've talked about pain. I've talked about weird symptoms in the saddle region. I've talked about incontinence. The other one is for blokes. So if you all of a sudden can't have an erection, and this sort of has been working okay for you up until now, and it's a sudden change in your function in that area. So a sudden, inability to have an erection, we want to know about that. And it's so personal, isn't it? It can be so embarrassing. And actually, when I talked with this guy from the country who ended up in the wheelchair, when I questioned him closely, I said, have you had any trouble with your bowels and your bladder? And he said, oh, well, actually, that's weird, because I've been sort of wetting my pants a bit. And I said, well, how are your erections going? Have you been able to have an erection? He said, oh, I didn't think that was related, but yeah, I haven't been able to have an erection for a few days. And I said, did you talk with your doctor about it? And he said, no, I was embarrassed. I didn't think it was anything to do with that. And I'm like, oh, because for any health professional, we hear those collection of symptoms and we think, oh my goodness, okay, we need to get you assessed straight away. So spinal cord compression can be reversed, it can be treated, but it's got to be got onto really fast. So if that's any of you, if those symptoms are anything that you're experiencing, we want you to see the doctor straight away. So the other thing I wanted to just touch on before I finish up, because I have been talking for some time, is there are some clinical trials in... one thing I forgot to mention. Sorry, I have it on my list and I just didn't mention it. So there is some evidence around medicinal cannabis as a medication for peripheral neuropathy. And I know that's something that a lot of people in our community are very interested in our NET community. There's a fantastic video that we had Dr. Judith Lacey come and do with us on a Facebook Friday last year, so I'll make sure there's a link in the notes about lots of different information about medical cannabis. So if you want to watch that video, see the link in the notes about that. So clinical trials. So that's tweaked my memory, because there's lots and lots of clinical trials that are looking at what use and what side effects there are for medical cannabis. But there are other trials that are looking specifically around peripheral neuropathy, both in terms of measuring intervention, so seeing what things work, testing new drugs, but also really trying to get a handle on what the experience is for patients who experience this ongoing. So I'll put a couple of links in the notes for relevant clinical trials that look to me on clinicaltrials.gov. They look like they are currently recruiting for a peripheral neuropathy. See, it's hard even for me to say, and I say it almost every day. But also, obviously, with anything related to clinical trials, talk with your own doctor. All clinical trials have what they call inclusion and exclusion criteria. So you've got to tick a number of boxes to be considered eligible for a trial. There's also a few boxes that if you tick those, they say, look, thank you very much, but, we can't, your situation won't be similar enough to everyone else in the trial to be able to really compare apples with apples. So we, thank you, but no thank you. So yeah, just wanted to mention about clinical trials. So I'm just going to have a look at the questions and see if there's anything that anyone's asking. I hope that I've answered the questions that people put in ahead of time. So, but if you've got a question, now's your last chance to ask it in to have me answer it live. Otherwise, put questions in when you watch this video and I'll attempt to hop in later and give you an answer for it. So, moving on, I've just before I finish, I always do a couple of plugs. So this is, if you're watching later via YouTube, this will all be out of date now. So feel free to press the end button and thank you for joining me. But if you're watching live, don't finish up yet. The first thing is, last week I put in a link into our Facebook private discussion group. We also sent the link out via email to everybody on our support group database, as well as in our e-newsletter that was sent out last week. So if you haven't got that, I'll make sure there's a link in the notes of how to subscribe to that one. What we're wanting to do is really get some good information about people and their feelings around face-to-face support groups and returning to face-to-face support now that we've got a vaccine that's being delivered in the community for COVID. I am so thrilled, and I'd wanted to thank you all in person if I could. I hopped in this morning to check. I've had 113 people who have filled that survey in. I think that's extraordinary. I know there have been so many surveys for people with cancer related to COVID, and I'm all surveyed out, and I'm just so grateful to you all for giving your time and your thoughts when, this is something that we know you get fatigued from. It's so valuable. The survey is going to be open for another week and a half. So I think I started off saying the 10th of May, and now we're going to extend it out to the 12th of May to give people a couple of weeks after getting the e-newsletter link. So if you haven't had a chance, please do put it on your list of things to do, or after the video, I'll put it in the notes, the link as well. So if you're in Australia and you're interested in having your say about face-to-face support groups returning post-COVID, I'm so keen to hear your feedback. The other thing that we did ask in that survey was about the Facebook Friday videos, and really asking whether you find them helpful, what else you would like to see in them, anything that you would like us to change. So that's a chance to have feedback too. If you live, 500 kilometres from a face-to-face support group and you think, oh, that's probably not relevant for me, then think again. We still want to know what your thoughts are. Two more things quickly. First thing is that we've got a rebranded, new, fresh version of our nutrition booklet, which is super exciting because we had run out of the physical copies, and I know there's a few people on our waiting list waiting for us to send you out a nutrition booklet version. So they're being printed as we speak. They haven't arrived at my place, which is where the volunteers come to do all of our mail outs. So as soon as they arrive, we'll start sort of catching up with people who have ordered a physical booklet. For those of you who have a physical booklet at home, I did ask what changes have been made, and the changes are minor. Probably the biggest change is that they were all branded Unicorn Foundation, and they don't they don't have, obviously we haven't been Unicorn Foundation for over a year now, so they've been refreshed to go with our new look and feel, and all of the web links and things for Neuroendocrine Cancer Australia are now current. So if you have a physical booklet, you don't need to replace it. You don't need to print out a new version. You can hang on to that book and be very confident that the information is still very current and relevant. But we did get our two expert NET dietitians to review the content of the booklet before we did a reprint, just to make sure that it was still dandy to use. And there's been some very minor tweaks, but essentially the old booklet is fine to use or to continue using if you've still got one. Now, the last thing I wanted to give a plug to, and this is probably really, really important, I probably should have plugged it first, is that next week I am super excited that Dr. John Layden will be joining us for Facebook Friday Live. He's promised, so Dr. John Layden, for those of you who don't know, is an anaesthetist, but he's also one of the co-founders of Neuroendocrine Cancer Australia, and the Layden surname might be familiar because John's sister is Simone is the CEO of Neuroendocrine Cancer Australia, and John was the chair of our board for many, many years and is still on the board and an active behind the scenes presence. John is an anaesthetist, as I mentioned, and he's got a lot of expertise on the management of carcinoid crisis. So different from carcinoid syndrome, which I talked about last week, but carcinoid crisis, and particularly around the risk of carcinoid crisis in surgery. But what there is to know about carcinoid crisis generally, if John doesn't know it, then it's not worth knowing. I'm so excited. He has promised to join me without beeping machines or any gory scenes in the background. He'll be joining us at 1:00 p.m. Melbourne time next Friday to answer all of our questions about carcinoid crisis. I know that's been a particular concern and topic of conversation about lately because of the COVID vaccines and people feeling a bit worried about the very, very rare but present risk of allergies. But then it always brings up, these conversations always bring up the questions around, well, what about if I need a tooth removed or a knee replaced, or or other surgery, or if I'm allergic to bees and need to carry an EpiPen but also get carcinoid syndrome. These are questions that a lot of people with NETs have. So I'm really, really looking forward to grilling John next week. I'll make sure there's an event link up in our Facebook private discussion group for those of you who watch live, and you'll be able to join us and ask us all of your trickiest carcinoid crisis questions. So look, I'm going to leave it there. Thank you everybody for sticking with me. I know it's been a long one today and lots of detail. There'll be lots of links in the notes for those of you who want to drill down a bit further, but it's been fantastic chatting with you all today, and thank you, and I'll look forward to seeing you next week. Take care everybody.